Good afternoon, dear students. This is the first lecture of the course of Clinical Immunology and Allergology, and the topic is immunodeficiency. The immune system is a wonderful collaboration between cells and proteins that work together to provide defense against infection, as well as internally derived threats such as cancers. These cells and proteins do not form a single organ like the heart or liver. Instead, the immune system is dispersed throughout the body to provide rapid responses to infection. Immune cells and soluble factors, such as complement, are some of the major components of the immune system and have specific critical functions in immune defense. Functions of the immune system include protection of the body from the introduction of foreign cells and from the modified cells in the body, destruction of old, defective and damaged own cells as well as cellular elements that are not characteristic of this phase of the development of the organism, neutralization with subsequent elimination of all genetically alien for this organism high molecular substances of biological origin. When some component of the immune system does not work correctly, disorders occur. It may be either immunodeficiency, when a part of the immune system is missing or its function is reduced, autoimmune disorders, in which the body's own immune system attacks its own tissue as foreign matter, allergic disorders, in which the immune system overreacts in response to an antigen, cancers of the immune system, lymphomas, and leukemia. Immunodeficiency disorders. Defects in the development and functions of the immune system result in increased susceptibility to newly acquired infections, reactivation of latent infections such as cytomegalovirus, Epstein-Barr virus, and tuberculosis, in which the normal immune response keeps the infection in check but does not eradicate it, and increase the incidence of certain cancers. Some of these diseases may result from genetic abnormalities in one or more components of the immune system. These are called congenital or primary immunodeficiencies. Other defects in the immune system may result from infections, nutritional abnormalities, or medical treatments that cause loss or inadequate function of various components of the immune system. These are called acquired or secondary immunodeficiencies. The primary immunodeficiency are a group of disorders caused by basic defects in immune function that are inherent in the cells and proteins of the immune system. Some affect a single cell or protein of the immune system, and others may affect two or more components of the immune system. There are more than 300 primary immunodeficiency diseases. The prevalence varies depending on the type of primary immunodeficiency. While selective IgA deficiency is common, 1 in 223 to 1 in 1,000 of population. Other immunodeficiencies, such as severe combined immunodeficiency, are fortunately rare, 1 in 58,000. As many immunodeficiencies are continually being discovered, the exact prevalence is unknown, so it's estimated to be low. Primary immunodeficiencies are classified by the main component of the immune system that is deficient, absent, or defective. Humoral immunodeficiency, B-cell defects, cellular immunodeficiencies, T-cell defects, combined humoral and cellular immunity deficiencies, disorders of phagocytic cells, and disorders of complement system. Classification of internal union of immunological societies include predominantly antibody deficiencies, T-cell immunodeficiencies or combined immunodeficiencies, syndromic immunodeficiencies, complement defects, phagocytic defects, defects of innate immunity, diseases of immune dysregulation, autoinflammatory disorders, and phenocopy of primary immunodeficiencies. Acquired or secondary immunodeficiencies might be defined as a transient or persistent impairment of the function of cells or tissues of the immune system, caused by factors that are not intrinsic to the immune system. Several factors and conditions may impair different components of the immune system, alone or in combination, to induce an increased susceptibility to infections. The management of a patient with secondary immunodeficiency should be focused on the improvement of the primary condition and, when possible, the removal of the offending environmental factor. Causes include systemic disorders, for example, diabetes mellitus, undernutrition, HIV infection, cancers, immunosuppressive treatments, cytotoxic chemotherapy, bone marrow ablation before transplantation, radiation therapy. Secondary immunodeficiency also occur among critically ill, older, or hospitalized patients. Prolonged serious illness may impair immune responses. Impairment is often reversible if the underlying illness resolves. Evaluation of the immunodeficiency include history, physical examination, initial testing, and additional testing. History and physical examination are helpful but must be supplemented by immune function testing. Prenatal testing is available for many disorders and is indicated if there is a family history of immunodeficiency and the mutation has been identified in family members. Clinicians should determine whether patients have risk factors for infection or a history of symptoms of secondary immunodeficiency disorders and or risk factors for them. Age, when recurrent infection begin, is important. In general, the earlier the age at onset in children, the more severe the immunodeficiency. Often, certain other primary immunodeficiencies, for example, common variable immunodeficiency, do not manifest until adulthood. A meticulous history and comprehensive physical examination is critical to diagnose primary immunodeficiencies. Clues to the correct diagnosis may include history of recurrent infections, presence of affected family members, physical findings related to growth and development, and presence or absence of peripheral lymphatic tissue. Immunodeficiency typically manifests as recurrent infections. Immunodeficiency should be suspected when recurrent infections are the following: severe, complicated, in multiple locations, resistant to treatment, caused by unusual organisms present in family members. Other features raising suspicion of an underlying immunodeficiency include skin rash, chronic diarrhea, failure to thrive, hepatosplenomegaly, chronic osteomyelitis, mouth ulceration, and autoimmunity. Early identification and management of primary immunodeficiency are vital to minimize complication and improve outcomes. The 10 warning signs published by the Jeffrey Model Foundation help to alert screening is initiated in situations where these criteria are met. The presence two or more of the warning signs should trigger investigation for PID. The 10 warning signs of primary immunodeficiency include 8 or more new ear infections within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months on antibiotics with little effect, 2 or more pneumonias within 1 year, failure of an infant to gain weight or grow normally, recurrent deep skin or organ abscesses, persistent rash in mouth or elsewhere on skin after each one, need for intravenous antibiotics to clear infections, 2 or more deep-seated infections, a family history of primary immunodeficiency. Physical examination. Patients with immunodeficiency may or may not appear chronically ill. Macular rashes, vesicles, pyoderma, eczema, petechia, alopecia, or telangiectasia may be evident. Cervical lymph nodes and tendinoid and tonsillar tissue are typically very small or absent in T-cell immunodeficiencies despite a history of recurrent infections. In certain other immunodeficiency, for example chronic rheumatous disease, lymph nodes of the head and neck may be enlarged and separative. Tympanic membranes may be scarred or perforated. The nostrils may be crusted, indicating purulent nasal discharge. Chronic cough is common, as are lung crackles, especially in adults with common variable immunodeficiency. The liver and spleen are often enlarged in patients with common variable immunodeficiency or chronic rheumatous disease. Muscle mass and fat deposits of the buttocks are decreased. In infants, skin around the anus may break down because of chronic diarrhea. Neurologic examination may detect delayed developmental milestones or ataxia. Characteristic clinical findings in some primary immunodeficiency disorders. On this slide, you can see some of immune and non-immune clinical signs of primary immunodeficiency. And for example, findings in hyper IgE syndrome, top syndrome, pustular eruption of the face, chronic dermatitis on the lower back, characteristic faces with coarse face features, broad nasal bite, large bulbous nose, prognatism, high arched palate, joint hyperextensibility, and non-immune manifestations are often more easily recognized than those of the immunodeficiency. Initial testing, if a specific secondary immunodeficiency disorder is suspected clinically, testing should focus on that disorder. Several tests are recommended for initial evaluation for suspected primary immunodeficiency. Tests are needed to confirm a diagnosis of immunodeficiency. Initial screening tests should include common blood count with manual differential, quantitative immunoglobulin measurements, antibody titers, skin testing for delayed hypersensitivity, chest X-ray. If results are normal, immunodeficiency, especially Ig deficiency, can be excluded. If results are abnormal, further tests in specialized laboratories are needed to identify specific deficiencies. If clinicians suspect that immunodeficiency may be still developing, tests may need to be repeated with monitoring over time before a definitive diagnosis is made. Common blood count can detect abnormalities in one or more cell types, characteristic of specific disorders as in the following. Neutropenia may be congenital or cyclic or may occur in a plastic anemia. Lymphopenia suggests a T-cell disorder because 70% of circulation lymphocytes are T cells. Leukocytosis that persists between infections may occur in leukocyte adhesion deficiency. Thrombocytopenia in male infants suggests Wiskott-Aldrich syndrome. And anemia may suggest anemia of chronic disease or autoimmune hemolytic anemia, which may occur in common variable immunodeficiency and other immunodeficiencies. Quantitative serum Ig levels are measured. Low serum levels of IgG, IgM, or IgA suggest antibody deficiency. An IgG level less than 200 mg per deciliter usually indicates significant antibody deficiency. Also, such levels may occur in protein-losing enteropathies or nephrotic syndrome. IgM antibodies can be assessed by measuring either hemagglutinin titers, anti-A and anti-B. Ig antibody titers can be assessed in immunized patients by measuring antibody titers before and after administration of vaccine antigens. Nature antibodies may also be measured, for example, antistreptolizin or chest X-ray may be useful in some infants. An absent thymic shadow suggests a T-cell disorder, especially if the X-ray is obtained before onset of infection or other stresses that may shrink the thymus. Lateral pharyngeal X-ray may show absence of adenoidal tissue. Additional testing. Lymphocyte subpopulation and proliferation tests. Lymphocytes, T and B cells, can be divided into various subpopulations. For example, Hepatitis cells, also called CD4 plus cells, and cytotoxic T, CD8 plus cells. A count of the different kinds of lymphocytes in the blood can help identify which primary immunodeficiency is present. In addition to counting how many lymphocytes there are, it's also important to test how well they work. For example, certain tests identify how well these cells multiply or proliferate when they are stimulated to do so by chemicals or antigens that normally trigger an immune response. These tests are performed based on clinical features and results of the screening tests. If patients have recurrent infections and lymphopenia, lymphocyte phenotyping using flow cytometry and monoclonal antibodies to T, B, and nature killer cells is indicated to check for lymphocyte deficiency. If cellular immunodeficiency is suspected, the T-cell receptor excision circle track test can be done to identify infants with low T-cell counts. If tests show that T-cells are low in number or absent, in vitro mitogen stimulation studies are done to assess T-cell function. If MHC antigen deficiency is suspected, serological HLA typing is indicated. If the type of pattern of infection suggests complement deficiency, the serum dilution required to lase 50% of antibody-coated red blood cells is measured. This test, called TH50, detects complement components deficiency in the classical complement pathway, but does not indicate which component is abnormal. A similar test can be done to detect complement deficiency in the alternative pathways. Granulocyte function tests. Neutrophils, eosinophils, basophils, and mast cells are together known as granulocytes. Normally, these cells, mainly neutrophils, produce hydrogen peroxide, sometimes called reactive oxygen, to kill bacteria and fungi. The amount of hydrogen peroxide produced is usually measured using a laboratory test called the dehydroamine oxidative burst test. This is an important diagnostic test for the primary immunodeficiency known as X-linked chronic lymphomatous disease, in which the neutrophil count is normal or high, but these cells do not work properly. Other tests are used to assess how well these cells migrate toward an attractant and how effectively they kill and swallow bacteria. Genetic testing. Primary immunodeficiency are caused by defects in the genes that are involved in the development and working of the immune system. The exact genetic defects that cause some primary immunodeficiencies are known. This includes severe combined immunodeficiency, chronic glomerular disease, hyper IgE syndromes, and complement defects. These defects are mostly inherited from the patients, but others can arise through genetic mutations that happen during pregnancy. By analyzing a patient's DNA, we can identify any defects present, and therapy confirms the diagnosis of a specific primary immunodeficiency. Help in decisions about primary immunodeficiency treatment, including replacement of the defective gene in those countries where this is being performed. Predict how the primary immunodeficiency will progress and affect the patient in the future, the prognosis. Check if an unborn fetus has a genetic defect that causes a primary immunodeficiency. Help in counseling adults with a primary immunodeficiency who wish to have children. Treatment of immunodeficiency disorders generally involves prevention infection, managing acute infection, and replacing missing immune components when possible. Infection prevention. Infection can be prevented by advising patients to avoid environmental exposures and not giving them live virus vaccines. Management of acute infection. After appropriate cultures are obtained, antibiotics that target likely causes should be given promptly. Sometimes surgery, for example, drain abscesses, is needed. Usually self-limited viral infections cause severe persistent disease in immunocompromised patients. Antivirals may be life-saving. Replacement of missing immune components. Such replacement helps prevent infection. Therapies used in more than one primary immunodeficiency disorder include the following. Intravenous immunoglobulin G is effective replacement therapy in most forms of antibody deficiency. Subcutaneous immunoglobulin can be given instead of intravenous IgG. And subcutaneous immunoglobulin can be given at home, usually by patients themselves. Hematopoietic stem cell transplantation using bone marrow, cord blood, or adult peripheral blood stem cells is effective for little T cell and other immunodeficiencies. Retroviral vector gene therapy has been successful in a few patients with X-linked and adenosine deaminase deficient severe combined immunodeficiency. But this treatment is not widely used because some patients with severe combined immunodeficiency developed leukemia. Key points. Consider a primary immunodeficiency if infections are unusually frequent or severe, particularly if they occur in family members, or if patients have thrush, oral ulcers, periodontitis, or certain skin lesions. Do a complete physical examination, including the skin, all mucous membranes, lymph nodes, spleen, and rectum. Begin testing with common blood count with manual differential, quantitative Ig levels, antibody titers, and skin testing for delayed hypersensitivity. Select additional tests based on what type of immune defect is suspected: humoral, cellular, phagocytic cell, or complement. Test the fetus using fetal blood, chronic virus sampling, or culture amniotic cells if family members are known to have an immunodeficiency disorder. Teach patients how to avoid infections, give indicated vaccines, and prescribe prophylactic antibiotics for patients with certain disorders. Consider immunoglobulin replacement for antibody deficiencies and hematopoietic stem cell transplantation for severe immune deficiencies, particularly T cell immune deficiencies. And the lecture is over. Thank you for your attention.